And welcome to Geriatric Grand Rounds. Thanks for joining us this morning. A few announcements before we get to today's presentation. Our next Grand Rounds will be on February 4th, and our presenter will be Dr. Megan Gauss, one of our geriatric fellows, and she's going to be talking about depression in the elderly. Our next journal club is February 11th, and our presenters are Drs. Carrie Hornay and Gretchen Oros, so please join for that. Other announcements: after today's presentation, you will receive an email with a link to the recording of today's presentation and a copy of the PowerPoint. There will also be a link to an online evaluation, so if you could please take a couple minutes to fill that out, that's really helpful for us and for our presenters. Any questions that come up during the presentation, please submit those in the chat or the Q&A box anytime during the talk, and we'll have time for questions and answers at the end of the presentation. So it's my pleasure to introduce our speaker today, one of our outstanding geriatric fellows this year, Dr. Tasmia Ahmed. Dr. Ahmed is a family medicine physician. She trained at Jamaica Hospital Medical Center in Queens, New York City, and is now completing her geriatrics fellowship with us. So she's going to talk to us about sleep in older adults today. So welcome, Dr. Ahmed.
Good morning, everyone. So today my presentation is on sleep changes and sleep-related disorders in the elderly. So just to go over some quick sleep facts, more than 50% of geriatric patients report difficulty sleeping, and insomnia is actually not defined by the loss of sleep during the night, but rather by the drowsiness, difficulty concentrating, headaches, irritability, and other problems patients may have during the daytime. Adults who get less than 7 hours of sleep per night on a regular basis are more likely to have chronic disease such as diabetes, asthma, or cancer. And over 70 million Americans, about 22%, suffer some kind of sleep disorder. And of those, over 60% have a chronic sleep disorder. And almost everything we know about sleep was discovered very recently within the last 30 years. So in the next section, we'll talk about normal sleep structure and physiology. So for the sleep architecture, there are two types of sleep. One is the non-rapid eye movement, non-REM sleep, and that's divided into 4 stages, stages 1, 2, 3, and 4. And then you have the rapid eye movement, REM sleep. A sleep episode begins with a short period of non-REM sleep at stage 1, and then it progresses through stage 2, 3, and 4, and then finally to REM. And then over the course of the night, non-REM and REM sleep alternate cyclically. The function of the alterations between these two types of sleep is not completely understood yet, but studies have found that irregular cycling or absent sleep stages are associated with sleep disorders. For example, instead of entering through non-REM sleep, which is typical, people with narcolepsy will enter sleep directly into the REM stage. This is a graphic showing the different types of sleep stages that you'll cycle through the night. The non-REM portion is about 75 to 80% of total time spent in sleep. And the REM is about 20 to 25% spent in sleep. The average length of the first sleep is about 70 to 100 minutes. And then later cycles get longer, lasting about 90 to 120 minutes. The REM sleep increases as the night progresses. And as the sleep episode progresses, the stage 2, which is right here, begins to account for the majority of the non-REM sleep. And stages 3 and 4, which is your deeper sleeps, they may actually disappear altogether as you continue to sleep during the night. So just to go into a little bit more about the 4 stages of non-REM sleep. So for stage 1, this one serves as a transitional role in the sleep stage cycling. The average person's sleep begins in stage 1 and it lasts about 1 to 7 minutes. And it constitutes about 2 to 5% of total sleep. In this stage, a person will be easily, their sleep will be easily interrupted by disruptive noises. And the brain activity on EEG transitions from wakefulness or rhythmic alpha waves to mixed frequency waves. In stage 2, this stage lasts about 10 to 25 minutes in the initial cycle, and then it lengthens with each successive cycle and eventually constitutes about 45 to 55% of the total sleep episode. A person in stage 2 will require a more intense stimuli than stage 1 to awaken. And brain activity on EEG shows low voltage, mixed frequency activity, characterized by sleep spindles, which is right here in the underlying portion, and K complexes, which is the arrow here. It's hypothesized that the sleep spindles help with memory consolidation. And it's been found that people who learn a new task have a significantly higher density of sleep spindles than those in a control group. Stages 3 and 4 are usually grouped together, and they're collectively referred to as slow wave sleep, most of which occur during the first third of the night. Stage 3 lasts only a few minutes and constitutes about 3 to 8% of sleep. And EEG shows increased high voltage and slow wave activity. Stage 4 will last about 20 to 40 minutes in the first cycle and makes up about 10 to 15% of sleep. And arousal threshold is highest in stage 4. And stage 4 is also characterized by increased amounts of high voltage and slow wave activity on EEG. Now for REM sleep is defined by the presence of desynchronized brainwave activity, muscle atonia, loss of reflexes, and burst of rapid eye movements. During the initial cycle, it lasts about 1 to 5 minutes and becomes progressively prolonged as sleep progresses. And dreaming is most often associated with REM sleep. And it's also found to be important for memory consolidation. Some of the physiological changes during sleep, when you're comparing non-REM to REM sleep, they're almost completely opposite. So your heart rate will slow down during non-REM sleep, whereas in REM, it'll increase. Blood pressure will decrease in REM sleep, whereas with REM, it will increase. And then as we said, muscle tone, in non-REM is similar to wakefulness, whereas in REM, it'll be absent. For respiration, it'll decrease in non-REM sleep, whereas it can increase or vary during REM, and coughing is suppressed. Data suggests that hypoventilation occurs during non-REM and possibly during REM sleep. And this is mainly reduced due to reduced pharyngeal muscle tone, reduced rib cage movement, increased upper airway resistance, and due to loss of tone in the intercostals and upper airway muscles. And also what's not listed here is endocrine functions. And these are also influenced heavily by sleep, such as growth hormone secretion, thyroid hormone, and melatonin secretion. So there are two major sleep regulatory systems. One is the homeostatic sleep-wake process, and this regulates the intensity of sleep. And then there's the circadian timing system, and this regulates the timing of sleep. So the homeostatic process leads to an increase in pressure for sleep that builds up in our body as our time awake increases. The pressure gets stronger the longer we stay awake and decreases during sleep, reaching a low after a full good night of quality sleep. And again, the homeostatic process begins to build after we awaken. So here you can see that as during the day, as the person is awake, the pressure continues to build. And then at night, it'll decrease, and then it'll go back to the beginning of the cycle again. Not getting adequate sleep causes a sleep debt to build over time. And this sleep debt is needed to be paid down. It doesn't need to be paid back hour to hour, because studies show that those with sleep debt will have a higher intensity of sleep with more slow sleep wave during REM. And this is thought to be due to the homeostatic process. So you'll just sleep, if you don't sleep well one night, the next night you will most likely go into a much deeper sleep. The circadian rhythm, so the circadian rhythms are internally driven cycles of biochemical, physiological, and behavioral processes that rise and fall across a 24-hour day. And these rhythms promote sleepiness before usual bedtime. They help initiate sleep, and then they begin promoting wakefulness before usual wake-up time in the morning. A peak in wakefulness occurs in the evening, a few hours before your usual bedtime, for a person that's on a normal daytime activity schedule. And this can be experienced by enhanced alertness in the early evening, even after being awake for long periods of time. And this evening peak in alertness makes it difficult to go to bed earlier, and this is called a wake maintenance zone. Then the pacemaker gets us ready for sleep by reducing the wakefulness process before the expected bedtime, which promotes sleepiness and sleep onset. So throughout the day, you have that homeostatic process building up, getting you ready for sleep and increasing the drive for sleep. Whereas the circadian rhythm here will keep you awake right up until your bedtime. And then as it starts to decrease, sleep onset is started. And then there's also a role for melatonin. So melatonin is the main hormone synthesized and secreted by the pineal gland, and excitatory signals from the suprachiasmatic nucleus, which we'll talk about more later, suppresses melatonin and promotes wakefulness during the day in response to light. And then this inhibition is released in a dark phase and leads to a melatonin release and sleep promotion. Melatonin is secreted at night with maximum plasma levels that occur around 3 to 4 a.m. And the rise of melatonin secretion correlates with an increase in the pressure to sleep about 2 hours before a person's regular bedtime. So all these processes work together to help initiate and maintain sleep. In order to get a restful sleep, there needs to be synchronization of both the homeostatic and their circadian process. So this red line here is our circadian process, and the blue represents the homeostatic process. So if you are active during the day and sleep at night, then the homeostatic sleep drive and the circadian wakefulness rhythm are synchronized. Wakefulness and sleep pressure rise during the daytime, with wakefulness overriding the pressure for sleep. Sleep onset occurs when the sleep pressure drive is high and the wakefulness is starting to drop. And then morning awakening occurs sometime after wakefulness begins to rise again, and it overrides that sleep pressure. This dashed line represents a potential increase in pressure to sleep, which will continue to build if sleep doesn't occur. So a little bit more about the circadian timing system, because it's so important to our sleep process. So the circadian timing system evolved to allow organisms to anticipate daily environmental changes. It enabled organisms to anticipate daily changes in temperature and radiation and food availability, rather than simply reacting to these changes. And in complex organisms, this clock optimizes internal physiology to reduce energy expenditure. The evolution of the central nervous system added a further dimension and required the brain to go offline or sleep during resting periods. And this offline period has serious consequences if it's compromised, leading to several brain and bodily dysfunctions. During sleep, the organism is obviously very vulnerable, and the fact that natural selection has not limited its occurrence is a testament to how critical sleep is to our survival. The master circadian pacemaker is located in the suprachiasmatic nucleus within the hypothalamus. And the circadian process transmits stimulatory wakefulness signals to these arousal networks in opposition to the homeostatic drive to sleep. The light and dark cycle of the sun is crucial for the circadian rhythm to work effectively and remain synchronized. So light will even pass through closed eyelids during sleep and signal the circadian pacemaker. The pacemaker is most sensitive to light in the morning and in the early evening. And for people on a regular schedule, bright evening light causes a phase delay, meaning they get sleepy later and wake up earlier. And bright morning light causes a phase advance, meaning that the person will get sleepy earlier in the evening and wake up earlier in the morning. So the sunlight will go through the eye, hit the retinal ganglion cells here, and the signals will travel through the retinal hypothalamic tract to the nucleus. And then those arousal signals will give an output and control the sleep-wake cycle. So your arousal, the REM sleep, timing, and consolidation, as well as sending signals to the pineal gland for the synthesis and release of melatonin. The suprachiasmatic nucleus is entrained to the external environment by the cycle of light and darkness. And so we kind of just went through all this with the melatonin. And the melatonin synthesis is inhibited by light and stimulated by darkness. And as we saw on the graphic earlier, the nocturnal rise in melatonin begins between 8 and 10 p.m. and peaks between about 2 to 4 a.m. and then declines gradually over the morning. This is another illustration just showing the important sleep structures located within the brain. So you have the pineal gland here. This will respond to inputs from the suprachiasmatic nucleus. It's also that site of melatonin production and increases melatonin production about 2 hours before sleep. Then you have your thalamus, and this is the site of the sleep spindle generation. The suprachiasmatic nucleus is here, and this controls the circadian timing of the sleep-wake cycle. And then also the lateral hypothalamus, it releases a molecule called orexin. And this is important because there's a new drug out that actually targets this, and we'll talk about this later. So changes in sleep structure and physiology in the elderly. So for sleep structure changes in the elderly, so with aging, there is an increase in the duration of stage 1 sleep and in the number of shifts into stage 1 sleep. So this causes a fragmentation of sleep. And if you remember, stage 1 sleep is the stage where you're most easily aroused and your sleep is easily disrupted by sounds. And then stage 3 and 4, which is your slow wave sleep, decreases with age. And in extreme old age, for those over 90, they actually may completely disappear. And slow wave sleep is your deepest sleep. So elderly patients are losing their ability to go into that very, very deep sleep. Circadian rhythm changes in the elderly. So there is an advance of timing of sleep to much earlier hours. And there's a reduced circadian rhythm amplitude. And this means that the homeostatic pressure to sleep can actually override wakefulness earlier in the day. And age-related changes in the pathway through the eye, such as yellowing of the lens, is also associated with greater reported sleep disturbances. And there's strong evidence that there's an altered pattern of electrical activity in the SCN. So this all means that these patients tend to go to bed earlier, and they're waking up much earlier than they would like to. So what does this all mean? So for our elderly patients, the first thing it means is that their time in bed is increased. So elderly patients spend more time lying in bed at night without attempting to sleep or unsuccessfully trying to sleep. Also, their total sleep period is increased. And sleep period refers to the time from sleep onset to the final awakening from the main sleep period. And this increases with age because of the increased number of awakenings. Their total sleep time will actually be reduced or unchanged. And total sleep time refers to the total sleep period minus the time spent awake during that sleep period. Sleep latency is variable, but it does seem to be more increased in our elderly patients. And sleep latency refers to the time from the decision to sleep to actually being able to sleep. And then the wake after sleep onset is also increased. And this refers to the time spent awake from sleep onset to final awakening. And a study attributed that 38% of nocturnal arousals is due to physical discomfort. So whether it's bladder distension, urinary urgency, restless legs, or shortness of breath. And then sleep efficiency is decreased. So this refers to the ratio of total sleep time to the time in bed. And despite all these changes, excessive daytime sleepiness is not a normal part of aging. So while our older patients might spend more time in bed to get the same amount of sleep as when they were younger, and they may have to take some daytime naps, but the total sleep time is actually only slightly decreased. So how to assess sleep and sleep hygiene. So some questions to ask our patients when they come in complaining about insomnia or sleep disturbances is you want to go through this list of questions with them. How has the patient been sleeping? When did the problem begin? And that will help differentiate between acute and chronic insomnia. Does the patient have a psychiatric or medical condition that might be contributing to insomnia? Is the sleep environment conducive to sleep? So are there noises? Are there interruptions? Is the room too hot or too bright? Does the patient report creeping, crawling, or uncomfortable feelings in the legs that are relieved by movement? This may relate to restless leg syndrome, and we'll talk about that more later. Does the bed partner report that the patient's legs or arms are jerking during sleep? Does the patient snore, gasp, or choke, which may be an indication of obstructive sleep apnea? Are they shift workers, or what are their work hours? What are the bedtimes and rise times on weekdays and weekends, which may indicate poor sleep hygiene? Are they using alcohol, tobacco, or caffeine prior to sleep? What are the daytime consequences the patient reports? And this one is very important, especially when considering treatment. And is the patient dozing off or having difficulties staying awake during routine tasks? And one of the ways to assess this is also is for the patient to keep a sleep diary for about 1 to 2 weeks. And here you want to have them record their bedtime, the total sleep time, the time until sleep onset, number of awakenings, use of medications, what time are they getting out of bed in the morning, rating the quality of their sleep, and what are their daytime symptoms. And it's important to remember that a person who complains of not sleeping a full 8 hours, but whose sleep is restorative and doesn't have any daytime symptoms, may just need reassurance. But a patient who complains of severe insomnia or any excessive daytime sleepiness should always be evaluated. So medications is, of course, one of the main things that we should always look at first to see if any of these cause insomnia. And I was surprised to see that how many of the medications that we do tend to give our patients can be a reason for the insomnia. And insomnia coinciding with introduction of a new medication should always be attributed to that medication until proven otherwise. And when a patient is on a medication that might be contributing to their insomnia, we should be attempting to decrease the dose, change the timing of the medication, or even discontinue as possible. So we have your SSRIs, which a lot of our patients are on, beta blockers, amlodipine, diltiazem, verapamil, and then your steroids. Also diuretics, because it can lead to nocturia. So you want to avoid it late in the day. You want to ask them not to smoke or drink caffeine before bedtime, because they do stimulate. And alcohol may be used by a lot of patients to induce sleep. But studies have shown that later on in the night, it actually leads to sleep fragmentation and can lead to poor sleep. There are several medical conditions that contribute to insomnia, and pretty much all our patients will have at least one of these. So you have your arrhythmias, your congestive heart failure, your COPD, dementia, and stroke, diabetes, hypothyroidism, BPH, CKD. So it's no wonder that so many of our patients are poor sleepers. You also want to evaluate for psychiatric disorders, and the big ones here is going to be your depression and your anxiety. So in depression, people will have trouble with sleep onset and maintaining their sleep, and they'll tend to be waking up earlier in the morning. And again, they'll have that decreased slow wave sleep, so they're not getting that deep restorative sleep that they should be. For anxiety disorder, they have trouble falling asleep, mainly because they're worrying throughout the night. And here again, it's just taking them longer to fall asleep because of their anxiety. So some assessment tools that we have available. So one is this one on the Pittsburgh Sleep Quality Index. This has been affirmed as reliable and valid, but it's very long. It's a 19-item scale, and the first part, or the first several questions, is not actually a scale. It's like the patient writes in how they think they're feeling. So it's very long, it's very cumbersome. So a lot of clinicians will not use this because it's just not practical in the clinic setting. And then you have the Epworth Sleepiness Scale. And this assesses subjective daytime sleepiness in older adults, but its reliability and validity has been questioned. There was a study of older adults with a mean age of 78, and it found that almost 60% had difficulty answering at least one question, and only 25% who complained about sleepiness had abnormal scores. And also participants rated their sleepiness as less severe than a close relative. And this discrepancy was actually more pronounced in our older adults. And then you have your Insomnia Severity Index. This one is designed to assess the nature, severity, and impact of insomnia and monitor treatment response in adults. It's easier to use, and it's been shown to be reliable and valid. It has about a 86% sensitivity and 87% specificity for detecting insomnia. But it has limited ability to differentiate between primary insomnia from insomnia due to comorbid diseases. And also it's not free, so you have to use it with permission. But it is the one that seems to be used most in clinical practice. So no matter what type of treatment you offer to your patient, a discussion on sleep hygiene has to be made. And so I won't read through all these, because I think most of us know most of this. Probably waking up at the same time each day will be important. The one thing that's not listed here that is crucial is avoiding electronic devices prior to going to bed, but because this can actually suppress bedtime melatonin production and adversely affect their circadian rhythm. So sleep-related pathology in the elderly. So we'll go over the types of insomnia and also some of the big disorders to rule out. Some of these, especially obstructive sleep apnea, could probably be a grand rounds presentation all by itself. So I'll be going through these pretty rapidly. So for the definition of insomnia, it's an experience of inadequate or poor quality sleep characterized by one or more of the following, which is difficulty falling asleep, difficulty maintaining sleep, waking up too early, or sleep that is not refreshing. It involves daytime consequences such as fatigue, lack of energy, difficulty concentrating, and irritability. And the evaluation and diagnosis of insomnia is a clinical one. It's based on a thorough clinical history of sleep problems, relevant comorbidities, and information from partners and caregivers is really important if they're available. So classifying insomnia, you have transient insomnia, where the patient will experience insomnia from no more than a few nights. Acute is less than 3 to 4 weeks, and chronic is more than 3 to 4 weeks. And transient and acute insomnia usually occur in people with no history of sleep issues, and is often related to an identifiable cause. And reasons could include acute medical illness, hospitalization, changes in sleep environment, medications, jet lag, or some kind of psychosocial stressor. Whereas chronic insomnia can be related to a variety of underlying medical, behavioral, and environmental conditions, and as well as medications. So when a patient comes in complaining of sleep impairment, they can be physically and mentally fatigued, anxious and irritable. As bedtime approaches, they can become more tense, anxious, worried about their health, death, work, and personal problems. It increases the risk of accidents, malaise, and chronic fatigue. And it can also decrease memory and concentration. They can have impaired performance on psychomotor tests. There's an increased risk of falls, cognitive decline, and some studies have shown a higher mortality rate. The non-pharmacological treatments that we have for insomnia, again, sleep hygiene, and this should be tailored and applied to every single patient that is complaining about sleep issues. Adjusting the dose and timing of certain medications that may be contributing to insomnia, and also setting reasonable expectations and explaining how anxiety leads to a vicious cycle. If there's minimal or no impairment in daytime functioning, they may just need some reassurance that the symptoms are not pathological or damaging. Some behavioral therapies that are available. So behavioral therapies, they aim to change the patient's bad sleep habits and to reduce autonomic arousal and alter dysfunctional beliefs or attitudes that they can have about sleep. So the first one is relaxation therapy. And this is based on observations that patients with insomnia often display high levels of physiologic, cognitive, and emotional arousal, both at night and during the daytime. So one way to do this is called progressive muscle relaxation. And this reduces somatic arousals such as muscle tension. There's also attention focusing with imagery training or meditation. And this is intended to lower pre-sleep cognitive arousals, such as intrusive thoughts or a racing mind. And relaxation therapy is useful for both sleep onset and sleep maintenance insomnia, but it does require regular practice with a trained professional over a period of several weeks. Then you have your sleep restriction therapy. Poor sleepers, they often increase their time in bed in an effort to provide more opportunity for sleep. But this has been found to result in fragmented and poor quality sleep. So sleep restriction therapy reduces the amount of time spent in bed in order to increase the percentage of time spent asleep. And this improves the patient's sleep efficiency, which is that ratio of time asleep to time in bed. So for example, a patient who reports staying in bed for 8 hours, but only sleeping an average of 5 hours would be told initially to decrease their time in bed to 5 hours. So they should only be going to bed when they're absolutely ready to fall asleep right away. And the allowable time in bed per night is increased 15 to 30 minutes as sleep efficiency improves. And these adjustments are made over a period of weeks until optimal sleep duration is achieved. When doing this, it's best to alter the bedtime and keep the rising time constant in order to maintain a regular sleep-wake rhythm. And by creating this mild state of sleep deprivation, this therapy promotes more rapid sleep onset and more efficient sleep. But in order to minimize daytime sleepiness that may occur, the time in bed shouldn't be reduced to less than 5 hours per night. And this therapy is modified in older adults by allowing them to have a short afternoon nap. Then you have your stimulus control therapy. And this is based on the premise that insomnia is a conditioned response to environmental cues. So the main objective is to reassociate the bed and the bedroom with a rapid onset of sleep. So going to bed only when sleepy, using the bed only for sleep or sex, getting out of bed and going into another room when you're unable to sleep, maintaining a regular morning rising time, regardless of how you slept the night before, and avoiding daytime naps. And clinical trials have documented the efficacy of stimulus control therapy for both sleep onset and maintenance. Cognitive behavioral therapy. This involves identifying dysfunctional beliefs and attitudes about sleep. So for example, patients who believe that sleeping 8 hours per night is absolutely necessary to function are asked to see if this is actually true for them. In a randomized placebo-controlled clinical trial of 78 adults with chronic and primary insomnia, cognitive therapy was compared with temazepam and placebo, and reductions in time awake after sleep onset was greater in the cognitive therapy group, so 55%, compared with temazepam, which is 46%. And follow-up showed that sleep improvements are better sustained over time with cognitive therapy. And the last one is bright light therapy. This is an effective way to establish a healthy sleep-wake cycle. So the timing of light therapy depends on the pattern of the sleep-wake cycle disturbance, and we'll go over this quickly later on. But several studies have demonstrated that the benefit of 60 to about 120 minutes of artificial light treatment at nighttime improve both the quality of sleep in both healthy and demented patients. And then your pharmacological treatments. So pharmacological treatment should only be used in the short term, and they should be used as a bridge to behavioral therapy. So behavioral therapy and sleep hygiene should be the first line. And until those are effective, we're able to give them pharmacological treatment with the goal that these medications will be taken away once the behavioral therapies start to take effect. So the 5 basic principles is you, of course, want to use the lowest effective dose, intermittent dosing if possible, so 2 to 4 times a week, short-term medications when prescribing, and regular use for no more than 3 to 4 weeks, gradual medication discontinuation to reduce rebound insomnia, and medications with shorter elimination half-lives are preferred to minimize daytime sleepiness. And an agreement should be reached with your patient on the duration of the medication treatment, because it can be very difficult to stop once initiated. So the first class we'll talk about is your benzodiazepines. So this is believed to improve insomnia by reducing REM sleep, decreasing your sleep latency, and decreasing nocturnal awakenings. The absorption of benzos is not affected by aging, but the aging population will have a decrease in lean body mass, a reduction in plasma proteins, and an increase in body fat. And this can result in an increased concentration of unbound drug and can increase the drug elimination half-life. And for those reasons, long-acting benzo should be avoided. And rebound insomnia can occur within 1 to 2 weeks of use. So if you continue the patient on this, their sleep may actually get worse. They may also experience hangover effects and impaired psychomotor performance and memory. The tolerance of these medications develops very quickly. They are addictive. They can cause daytime sedation. We want to avoid them in the elderly. For your non-benzo medications, so both benzos and non-benzos are receptor agonists. They have a common mechanism. They both work by binding to a specific receptor site on the GABA type A receptors, with the difference being that non-benzos are more selective for the alpha-1 subclass of receptors. And this causes sedation, but minimal amnesic or anticonvulsant or anti-anxiety effects compared to the benzos. Both classes of drugs treat insomnia-related parameters such as sleep latency, the number of nighttime awakenings, total sleep time, and sleep quality in short term, but they are not to be used for chronic use. So your first one is zolpidem, which is Ambien. This is usually used for sleep onset due to its short half-life of about 2.5 to 3 hours. It is contraindicated in patients with sleep-related breathing disorders, severe hepatic impairment, acute pulmonary impairment, or respiratory depression. But it does tend to be well tolerated in the elderly, with the most common side effects being nausea, dizziness, drowsiness, and rebound insomnia. It's not typically associated with hangover effects or tolerance. It doesn't alter the sleep architecture, but patients can become dependent with use more than 4 weeks. And now there is also a sustained release formulation that can be used for sleep maintenance. Then Zalplon or Sonata. This is used for sleep onset insomnia as well. It can be used specifically for treatment of midnight awakenings because it has a very short half-life of 1 hour. No major side effects have been reported. It tends to be safe and efficacious in our older adults for both short and long-term treatment. There's no tolerance, rebound insomnia, or withdrawal symptoms. So this one sounds pretty safe. Lunesta, so there was a randomized double-blinded study which showed that Lunesta significantly improved sleep latency and quality and depth of sleep, increased total sleep time, and reduced wake time after sleep onset. It also reduced the number and duration of naps needed by the elderly population, and its half-life is longer at 6 hours, so it can be used for sleep maintenance. The most common side effect was headache, and a meta-analysis of 5 randomized controlled trials showed that it's safe and efficacious in the elderly. So for your antidepressants, you have trazodone, and this is a non-tricyclic antidepressant with sedative properties. It has a long half-life of 10 to 12 hours. And it does change your sleep architecture by increasing that deep, slow wave sleep. It's often used to treat depressed patients with significant insomnia, but the efficacy in non-depressed patients is not known. And there was a review of 58 studies in which about 1,600 patients received trazodone at doses of 75 to 500 milligrams. And the most common side effects were drowsiness, tiredness, GI effects, dizziness, dry mouth, insomnia, headache, hypotension, agitation, tachycardia. And this prompted the Medical Academy of Sleep Medicine recommends that trazodone should not be used for sleep onset or maintenance because the harms outweigh the benefits. But we do see a lot of our patients coming in on trazodone for sleep. Then you have doxepin. This is the only FDA-approved antidepressant for insomnia at doses at 3 to 6 milligrams. It's a tricyclic antidepressant, and it's selective for your histamine 1 receptors. Studies of patients 65 and older with doses of 1 milligram and 3 milligrams have shown to have improved sleep measures. over a 12-week period. Improvements sustained, it also showed that improvements were sustained for a duration of 3 months. It's not associated with tolerance or anticholinergic side effects or cardiac repolarization. There's no risk of addiction or dependence, no incidence of withdrawal symptoms or rebound insomnia, and no residual symptoms the next day. So this is also sounds like a good option if the patient needs medical therapy. And then there's mirtazapine. This is a 5-HT2 antagonist. And one study showed that it did have significant improvement in sleep latency, efficiency, and awakenings after sleep onset after about 2 weeks of treatment. But because of conflicting evidence and habituation to its sedative effects, it shouldn't be used to treat insomnia if the patient doesn't also have concurrent depression. Then you have your MT1 and MT2 receptor agonist. This is Ramelteon, and it's been approved by the FDA for treatment of chronic insomnia in the elderly. One study showed that over 800 patients with chronic primary insomnia received either 4 milligrams, 8 milligrams, or placebo for 5 weeks. And they found a significant reduction in sleep latency at week 1 and week 5, and an increase in total sleep time in week 1. And there were no withdrawal effects that were noticed. Some non-prescription medications that you may see your patients coming in with, well, one is alcohol. So a lot of patients will use alcohol to promote sleep, but it can actually cause sleep disruption. It causes a decreased latency of sleep onset, increased slow wave sleep, and decreased REM during that first part of night, which is why a lot of patients will use it. But as the alcohol levels decline during the second half of the night, your REM sleep increases, there's sleep fragmentation, and then you have early morning awakenings. Antihistamines, this one you'll find a lot in the OTC medications at drugstores for the patients will buy in order for their sleep insomnia. But these are associated with cognitive impairment, your daytime drowsiness, and anticholinergic effects. And there's been no specific data to show that antihistamines can improve insomnia or prolong sleep. And of course, you want to avoid it in the elderly. And then we have melatonin. So some trials have shown that it can improve sleep quality and latency. But there's a potential lack of quality control in the OTC melatonin that's found. And also, we're not really sure about the timing of ingestion and the appropriate dosing. And then some herbal preparations that patients may be coming in with is valerian, chamomile, hops, kava kava, and passion flower. But randomized controlled trials have been performed on valerian, and the efficacy and safety data are mixed and lacking. And the same goes for all the other herbal preparations. And then there's a new medication. It's called Suvoxent. It's the first FDA approved dual orexin receptor antagonist. And this targets wakefulness promoting neuropeptides that regulate the sleep-wake cycle. And it decreases the sleep latency and increases the total sleep time. It's usually taken on an empty stomach, so the onset is faster, and it's recommended to take when the patient is able to sleep for at least 7 hours continuously. Studies have found no significant efficacy or safety differences between the elderly and the non-elderly. And the common side effects of it is somnolence, fatigue, and headache. But again, it's new, so long-term data is lacking. So this chart just goes through the medications that I just ran through quickly. It gives you the half-lives as well as the type of insomnia that it's best used for. So some common disorders related to secondary insomnia. You have your obstructive sleep apnea or your restless leg syndrome, rapid eye movement disorder, and circadian rhythm sleep-wake disorders. This is by no means an exhaustive list, but these are the ones that you'll see commonly in our patients. So for OSA, again, it's a distinctive snoring pattern. It's caused by intermittent airway collapse, periods of loud snoring or brief gasping followed by cessation of respiration, which can last about 20 to 30 seconds. It leads to sleep arousals due to desaturations. And the patients will come in with excessive daytime sleepiness, cognitive impairment, slowed response time, impairments in executive function. And formal evaluation of OSA should always be considered in the elderly who exhibit these typical symptoms. The mainstay of therapy is positive air pressure devices such as CPAP, and hypnotics and other sedative medications can actually worsen OSA. So you want to stay away from those. So that's why it's very important to rule out OSA in your elderly before you think about giving them any insomnia medications. For restless leg syndrome, the patient will complain of bubbly or creepy crawly sensation in the legs, tingling, tickling, restlessness, a stretching sensation, and these occur at rest and relief by movement. The prevalence is between 10 to 35% in patients over 60 years old. And it's commonly seen in the setting of iron deficiency, uremia, neuropathies, and cardiovascular disorders. A serum ferritin of less than 50 will correlate with severe symptoms, and a prevalence of restless leg syndrome is between, that is not right, but I think it's supposed to say between 15 to 40% of patients with uremia. So there is a diagnostic criteria, and all the criteria need to be met in order to diagnose RLS. So the urgency to move your legs starts or worsens when one is inactive or at rest, and gets better when they're moving. It's only occurring or worsens during the evening or night. And it's not attributed to any other medical conditions. There's also a scale that can be used. It's called the International Restless Leg Scale, and it's a 10-item measure of disease severity. And it's easy to use, and it's used pretty extensively in clinical practice. So for our RLS patients, some of the things that you can offer them is non-pharmacological treatment. So taking a hot shower or getting a massage before bedtime, having a regular sleep and wake times, regular exercise, and avoiding your caffeine, cigarettes, and alcohol before bedtime. But antipsychotics, antimimetics, antidepressants, beta blockers, some anticonvulsants and lithium are also known to exacerbate RLS. So you definitely want to do a med review to see if those could be contributing. For the pharmacotherapy, so your first line is going to be the non-ergotamine dopamine agonist. So you want to go towards the medications when the symptoms are impairing their function, their sleep, and their quality of life. And so you have your pramipexole, rohypnol, and rotigotine. I have a hard time saying these ones. So these are the ones that you want to start with. The dopamine precursors and the ergot-based dopamine agonists are effective, but they're more likely to cause augmentation, so an initial worsening of their symptoms. And if augmentation limits the use of dopamine agonists, then you go to your gabapentin or pregabalin. Although there are some studies that do argue that the gabapentin and pregabalin should be on your first line. And use of opioids should be limited, but may be useful in people who don't respond to the other types of treatment. Your rapid eye movement sleep behavior disorder. So this is your dream enactment disorder. And this can range from simple to complex vocalizations and body movement during REM sleep. And this occurs because there's no loss of muscle tone that you would typically see in REM sleep. And idiopathic RBD is linked to neurodegenerative disorders, specifically Parkinson's, Lewy body, and multiple system atrophy. And patients with RBD are alert, and they can immediately have vivid dream recall. There is a 16-item questionnaire that can be used to screen for RBD and other sleep disorders. And all patients with dream enactment history should be screened for OSA, which can mimic RBD. And although history might suggest RBD, polysomnography is often required to definitively diagnose it. So patients who have this disorder, you want to talk to them about injury preventing techniques. So having them sleep on the floor so they don't fall out of bed, patting the corners of furniture, keeping the windows and doors locked at night so they don't wander off, removing dangerous objects, using heavy curtains on bedroom windows to reduce sleep disruption, and in some cases, if it's really bad, asking the bed partner to sleep separately until they're treated. You want to discontinue medications that are known to exacerbate it, such as antidepressants, beta blockers, tramadol, or cholinesterase inhibitors. And if there is a comorbid depression, Wellbutrin is a preferred drug. You can also offer a bed alarm, and this consists of a pressure sensor that gets activated during dream enactment. So it'll play a pre-recorded message that'll tell the patient it's a dream and calm them down so they can go back to sleep. So of the drugs used, clonazepam is actually the first line. It's been shown to reduce motor behavior in 90% of patients, but obviously it's limited in elderly populations, and especially those with comorbid OSA. So then the next one is actually melatonin, and at high doses, melatonin can be as effective as clonazepam, and it's likely better tolerated, especially those with your neurodegenerative diseases. And then lastly, we have the circadian sleep-wake disorders. There's a whole list of them here, but the one that the elderly population mostly suffers from is advanced sleep-wake disorder. And so we'll go through that really quickly. So sleep-wake disorders, just want to go back real quick. So this is occurring mainly because there's a mismatch between the circadian rhythm sleep disorder and this would lead to an advanced sleep phase. So in the elderly, advanced sleep-wake phase disorder is the most common, and it's characterized by an advancement of the sleep-wake cycle. It presents as regular and involuntary sleep and wake times that occur several hours before their usual desired time. So patients typically report sleepiness during the early evening, and early sleep onset between 6 and 9 p.m., and spontaneous early awakening between 2 and 5 a.m. And even if they resist evening sleeping, they will still wake up very early and have daytime sleepiness. So a sleep wave a sleep log and monitoring is required to demonstrate a pattern of advancement in regular sleep time for at least 1 week. And sleep hygiene is actually, unfortunately, not much use except for avoiding long evening naps. And this just shows the treatment with light therapy. So light therapy is the first line treatment for this, which means that you want to, for this particular disorder, you want to reduce morning light to advance the phase and increase evening light, which delays the phase. So for this particular disorder, you want to, right here, you want to have the patient take a morning melatonin, and you want to expose them to evening light. And this will hopefully make them sleepy later in the night and allow them to sleep in a bit later into the morning. And I think we're all done. Those are my references. And thank you.
Thanks, Tasmia. Great presentation. I know we're about at the end of the hour, but may have time for a couple of questions before people have to hop off. Otherwise, maybe people can contact you directly if they have questions about the presentation.
Yeah, of course.
I don't see any questions coming in right now. So we'll go ahead and wrap up. Thank you so much for your presentation. And again, oh, hang on, we got one. Oh, great presentation is a comment. So thank you, Tasmia. And everyone, please look out for a link to the presentation, a copy of the slides, and the online evaluation form. Thanks for joining us this morning, and we'll see you next time. Have a good